Now, this afternoon, we have four speakers. And I'm delighted that we've been able to cover this very important topic of healthcare in rural Zambia. And Zambia has, because of its widely dispersed population, its vast size, there are special problems, of course, in providing healthcare across the country. And so there are two very innovative, I think, and successful initiatives that we're going to cover this afternoon. The first is medical licentiates. My predecessor as chairman here, Dr. James Cairns, was very much involved in the very early days of setting up the medical licentiate program. And it's grown very rapidly, and we'll be hearing about that from Dr. Petros Andreadis. Petros is a technical advisor and project manager for the training program of medical licentiates in Zambia, working with Solid Ahmed. This is a Swedish organization who provides funding, a Swiss organization, sorry, to provide funding for the program. He's a regular lecturer at Cambridge University on global health, teaching master students in global health. And so I'm delighted he's taken time to be with us this afternoon. Especially, he was involved in a car accident this morning, I'm sad to say, and he's come out relatively unscathed, but obviously a bit shaken. So, Petros, thank you so much for being with us in spite of this morning's accident. We're going to start with just a brief video on the medical licentiate program, and then Petros will pick up from there.
The global shortage of surgeons disproportionately impacts low and middle-income countries. To mitigate the chronic health workforce shortages, some countries train non-physician clinicians to perform procedures that were historically only carried out by doctors, a response termed task shifting and task sharing. The task sharing concept is one that is supported and recommended by the World Health Organization, and for 20 years, Zambia has invested in training medical licentiates to fill the human resource gap in the delivery of healthcare.
They've been able to save a lot of lives. In fact, to date, some of our districts, the people who are running the theaters, who are saving lives are the medical licentiates. They are able to do a cesarean section in the rural, remote parts of this country and save lives.
Their contribution to providing essential surgical services in district and rural hospitals in Zambia directly addresses a critical dimension of health equity.
Medical licentiates have really filled in the gap that has been there for some time because of the shortage of doctors.
Even when they come here, it's not that you have direct entries only, but you have a mixture of both in-service and direct entries. And those give a good buffer in terms of human resource. Where we are lacking in terms of numbers, they come in and help us mop up the few things that will be lagging behind in terms of being able to deliver service to the clients on time.
This is St. Margaret's Mission Hospital in Chifunabuli district in the Luapula province. The hospital is about 115 kilometers away from the provincial capital, Mansa. Evans Nyumbu is a medical licentiate practitioner and works for St. Margaret's Mission Hospital.
My favorite place is the theater. I love being in theater, operating on people.
Solidamed and Liechtenstein Development Service have been supporting the health sector in many ways.
And in our early support, we were involved in direct training and providing clinical expertise to help train up medical licentiates in things like surgery, pediatrics, etc. More recently, in the last 2 years, we've shifted our focus to supporting the systems that underpin good undergraduate clinical training. That is, we are assisting in improving the teaching quality. So that is helping doctors with teaching skills and what we call pedagogical skills. And we also helping to improve the learning quality. And in that space, we're working with partners at Heidelberg University to develop e-learning content and to help develop the learning platforms so that students, ML students, wherever they are in Zambia, can have access to good quality learning materials.
We also recognize that it's quite difficult for health workers, particularly in rural Zambia, to get good housing. And there isn't enough housing, and it's sometimes not in very good condition. And it's demotivating for them to stay in a rural area if they don't have good housing. So one of the things that we've done is set up a social enterprise that builds and rents houses as an affordable rent to healthcare workers. And it therefore creates a revenue stream whereby we can maintain those houses and even build some more.
Richard Tuchili is a fourth-year student at Levi Mwanawasa Medical University and worked as a clinical officer before enrolling into the program.
It has brought me to a realization that there's so much that I thought I knew, and being involved in the inner circles, it has made me a better clinician.
Medical licentiate practitioners are making a huge difference in the lives of many in rural parts of Zambia.
We need to find a way of continuing producing medical licentiates because they have a special role to play. And let me take this opportunity to thank SolidaMed and indeed other partners who helped us to come up with a curriculum and ensured that we translated that into the training of the medical licentiate.
With their rare skills, medical licentiate practitioners are filling the human resource gap in the delivery of healthcare.
Hello, everybody. John, are you okay if I go straight into the presentation?
Yes, please. Yes. Thank you, Petros.
Okay, I'm just trying to get my slides up. Okay, can everybody see that? Is that coming through?
Yep, yep,
Yes.
that's great.
Okay, thank you so much. First, let me say thank you very much for inviting me to this event. I must be honest, I didn't know the society existed until John reached out. I'm actually South African by birth. This is now 2 years I've been in Zambia, and I've very quickly fallen in love with the country. As John mentioned, I worked for SolidaMed, a Swiss organization in Africa, and I thought I'd just quickly say a couple of things about SolidaMed before launching into the ML program. So our focus is very much on rural health. So we have three arms to our program. One is the home building for health professionals, which you heard John Turney, my country director, talk about in the video, where we build houses for health professionals in rural areas. And we've set up a social enterprise, a non-profit, whereby we've arranged with the Ministry of Health that we will receive the housing support allowance that will go into maintaining the properties, but also any profits will go either into the hospital where the house is situated or into building new houses. And that's quite a significant program. And I believe we have over 80 houses now, and we're looking to expand quite rapidly. My colleague works on the decentralized nursing training, where we work with nursing schools in rural areas to produce more nurses in a different model, more of a vocational model, where they work directly in hospitals. And of course, there's my program, which is the Medical Licentiate program, which I've been the technical advisor and project manager on for the last 2 years. Now, just to provide a very quick update, some of you may or may not know what a medical licentiate is. Clinical officers have been in Zambia for many years. They clinical officers train and they get a diploma, generally a 2-year diploma, after which they move into hospitals and work in clinical spaces doing a limited number of activities. And about 20 years ago, the idea of the medical licentiates was born and integrated as part of the WHO shift towards taking existing clinicians and upskilling them and training them. Now, the focus of training medical licentiates has always been and still is 4 key areas, which is they go on to do further training in internal medicine, they do training in obstetrics and gynecology, in pediatrics, and of course, surgery. And a key part of their practice are the surgical skills. And a key focus of medical licentiates in Zambia was to bring down the maternal and child morbidity and mortality rates. So they were trained specifically for maternal and child morbidity in rural areas where women could not really get to key facilities, or there just weren't enough practitioners. So in terms of the evolution of my program, the program used to be run out of Chainama College of Health Sciences, and the program was effectively validated by UNZA, the University of Zambia. And 2 years ago, a new university was incorporated by an act of parliament called Levi Mwanawasa Medical University, also known as the National Health Research Training Center. It's quite a significant facility. It can hold many thousands of students, and there's currently, I believe, about 7,500 students registered in the university. So it's a significant facility. And the ML program was moved to LMMU when it absorbed Chainama College of Health Sciences. So LMMU absorbed Chainama College of Health Sciences as well as a few other institutions, and the program now exists under Levi Mwanawasa. Now, the key focus of the program is decentralized training. So Levi Mwanawasa, that green dot on the screen, is the central Lusaka focus, and it has a number of peripheral training sites all across Zambia, one in each province. And part of my job is to help assist develop the training coordination through this. So, for example, medical licentiates would go to certain key facilities for certain specialties when they're in their 3rd or 4th year. So they might go to Livingston and Mongu for internal medicine, for example. They might go to Solwezi for obstetrics and gynecology, or Mansa. They might go to Arthur Davidson and Ndola for pediatrics, and of course surgery in a number of facilities as well. So what we have over here is we have a central university based in Lusaka, and you have 2 cohorts, 3rd and 4th years medical licentiate students, who rotate on 4 rotations per year around the country. So the program started off as quite small, teaching about 30 to 40 students per year. It's now grown quite significantly, and there are 140 students in year 1 and 170 students in year 2. And as you can see, that exponential growth requires quite a complex system to get the students to their sites and get them training and getting the curriculum run through so that they attain their clinical competencies. And this is part of what Solidarmed does is, as I mentioned in the video before, we were directly bringing in experts to train medical licentiates, and it's quite easy to do that when you've got a small cohort. But now that we've got dozens, we need to actually have a system to be able to get them upskilled. And we do that by going to the hospitals and upskilling doctors, teaching them how to teach, and ensuring Levi Mwanawasa has the systems to make sure that the students can rotate. Now, in terms of what I do on my program, when I tell people I'm a project manager, they go, well, what does that mean? And essentially what we try to do is we say, well, we have an objective. We want to improve teaching amongst doctors, and we want to improve the learning environment for students. And this is what we've been doing at Solidarmed for the last 2 years. As an example, for improving teaching, we want to make more clinical lecturers. We want to develop more clinical lecturers. So in the last 2 years, we've sent 5 students for MSCs, so Masters in Health Professions Education. There's 2 students doing that. We've got a student doing a Master's in Digital Education because we've got quite a complex e-learning platform, and it's necessary to make sure that e-learning platform is maintained. We've got a student on epidemiology, and we've got a student on anatomy. We've also sent 11 students on clinical simulation, and I'll say more about that in a minute, and 14 doctors on a postgraduate diploma in medical education. So what we're trying to do is we're really trying to upskill the teaching capacity. So when the students get in front of a doctor at the bedside, a doctor who's never taught before, they've then got the skills to be able to say, well, what is it my students need to know? How do I package this information? What do I need to teach them, etc. As an example, we've sent 150 clinicians on an introduction to medical education program that we designed. That includes things like, how do you teach in a small group in a clinical space? Or how do you even teach in a clinical space when you're surrounded by patients and patients' families? There are certain sensitivities you need to maintain. How do you teach using traditional didactic principles? How do you design and run an examination, an OSCE, which is an objective structured clinical examination? And how do you mentor students? And this is not something that a lot of the doctors thought that they were going to do when they took on medical licentiate students. They'd never been a mentor. Most of their time is spent saving lives. And now they find themselves having to save lives, but also bring students along with them. And that requires a certain skill. So we've spent a lot of time teaching lecturers how to be teachers. But we do other investments as well. So for example, for improving learning, we've invested heavily in the e-learning infrastructure. That includes refurbishing a room and putting in a climate controlled server so that we can run an e-learning platform. So that if a student is in Mongu, or if a student is in Chipata or Mansa, they've got access to a platform where they can get hold of learning materials. And this is really important when you've got so many students. Textbooks are expensive. And it's very difficult to send students around the country with a box full of textbooks if they've each got their own textbook. And setting up a library at each of these facilities is also quite expensive. So we thought the e-learning platform would be a very useful way to get good quality e-learning materials to the students, so that if they're learning how to do a cesarean section in Chipata, they can also then go to the e-learning platform and get the requisite theoretical knowledge they need to know around that. We've also done training for the staff on blended learning. So how do you teach using technologies? And I spend a lot of time with my colleagues at Heidelberg University to develop blended learning assets. We do training on content creation and curation. So a lot of the lecturers who are currently teaching medical licentiates, they're quite new to teaching. They've never put together a lecture program before, or a course. So we teach them how to create content, especially e-learning content. And we've also set up a computer room in Lusaka, plus in several other places where we're upgrading the teaching and learning facilities. And all this is so that we can actually improve the ecosystem for students to learn and teachers to teach. A key thing that we do, and actually quite a resource intensive activity, is because this is a vocational program. And if anybody was early on the call, we were talking about there was hopes that the program was still practical and not entirely theoretical. To kind of maintain that, what we've done is we've started investing in clinical simulation skills labs. And what are clinical simulation skills labs? Quite simply, if we can get some sort of apparatus where we can train a student how to do a lumbar puncture, for example, on a mannequin, it's a lot better doing that than training them on a live person. So we've set up skills labs around the country so that students can learn the fine motor skills and the practical skills to be able to learn their craft. And we're actually planning on making significantly more investment in this over the next 3 years. We have skills labs in Chipata, in Mongu, here centrally in Lusaka, in Mansa, and we're about to build a brand new skills lab at Kafue Hospital, just south of us here. Quite an innovative thing that happened because of COVID, actually. COVID really put the brakes on teaching and learning over here, and it really put the brakes on us being able to create content with lecturers, because we weren't allowed to hold meetings, we weren't allowed to do face-to-face stuff, and actually because most of the teachers are clinically active in the hospitals, their time got captured by attending to COVID issues. So a lot of the teaching got constrained. So we were thinking, well, how can we get information out to students quickly and efficiently, and good quality information? And we've actually started up Southern Africa's second medical education podcast ever. The first medical education podcast was in South Africa on surgery. So ZMed podcast is produced by an in-house staff member in Saladar Med. You can see her face there. She's Mary Kuyela. She's a clinical officer, and she's training with us on clinical simulation as well. But she's produced 20 podcasts so far. She's on track to produce 50 podcasts by the end of the year. And these are all aligned to the medical licentiate syllabus and curriculum. So when a medical licentiate is anywhere in the country, they can actually get a low cost form of learning, because downloading a podcast is not a costly affair as, for example, downloading a video. These podcasts, there's been over 900 downloads now, and actually they've been downloaded on every single continent except Antarctica right now. So we're quite proud of ZMed podcast, because not only is it helping medical licentiates, it's also presenting a face to the world about the potential future of medical education in Zambia. And I do stress these are high quality podcasts. We've learned how to produce them. They're validated through university systems and by experts. So if anybody is medically oriented and you'd like to listen to season 1, by all means, please go ahead and download them. We'd certainly like feedback. Now, to finish off, because I know this time is running short, this is just to show the kind of evolution of medical licentiates over the last nearly 20 years now. It started very slowly, about 22, 23 in the first intake, and every 2 years, roughly, the program brought in new clinical officers to be trained as medical licentiates, and they would do an advanced diploma in clinical sciences. Solidar Med took over the program in 2010, and we started pushing and seeing how can we produce more medical licentiates. And we started supporting Chainama College of Health Sciences to do this. And we started getting people in every single year. And it was in 2019, as you can see, where there was quite a significant jump in student numbers. And that's entirely attributed to, as I mentioned before, Levi Mwadawasa Medical University. It was also 2018, 2019 when Solidar Med helped establish a new degree for the medical licentiate program. We revised the curriculum, we revised the learning outcomes. So it's now a Bachelor of Sciences in Clinical Sciences. It's no longer a diploma. And that's been quite a draw as well, as a lot of young people have seen a lot more value in having a bachelor's compared to a diploma. And we've really tried to focus the last 2 years of how we refine and support a new institution in delivering this program. And I should stress, Levi Mwadawasa is a brand new institution. It's learning how to be a university. So the last 2 years have been very challenging because doctors have had to learn how to be lecturers as students kind of descend upon them. And we've been trying to help with that support so that the students, that training that the students need isn't interrupted. In terms of where medical licentiates are placed, the purpose of a medical licentiate, the intention was that they would exist in rural areas so that they wouldn't be so focused in the urban centers and the peri-urban centers. And the graph on the left, or the map on the left, shows about 300 data points of medical licentiates and where they happen to be distributed across the country. And this was a very small piece of research that we did in 2019, 2020, to see where MLs are. And actually, with my colleague who's also on the call, Kuba, who you'll hear from next, we're now going to be updating this with the full list of medical licentiates. And we estimate there's between 500 and 600 MLs now practicing in Zambia. The map on the right just shows the density of MLs and where they're focused. And even though we'd like them, of course, to be rurally situated, you can see the heaviest concentration of MLs is, of course, Lusaka. And there's a string going off to the east all the way to Chipata and Tupetauka. And of course, the Copper Belt, there's quite a heavy concentration there. Now, Solidar Med has been working on this program, as I mentioned, for the last 11 years. We get quite substantial funding from the Liechtenstein Development Agency to do what we do. So the Liechtenstein Development Service is effectively the equivalent of DFID for the UK for Liechtenstein. And Liechtenstein, as you may well know, is a small autonomous principality, effectively appended onto Switzerland. Very small country, which you could probably walk across in a day. And it's quite a wealthy country. And it's been very generous with the ML program. And it contributes approximately 2.1 million Swiss francs every 3 years. So we have quite a healthy budget. And this has been really good in terms of making the investments that we need to make. For example, because the skills lab is a very costly piece of equipment to add to a hospital facility. Medical equipment is quite expensive. And Liechtenstein has been a very keen advocate of medical licentiates and the WHO program of task shifting and gap filling. So we're very appreciative of Liechtenstein to be able to allow us to do the work we do for Solidar Med. I also work very closely with Heidelberg Institute of Global Health. and with my colleague Sandra Bartet, Dr. Sandra Bartet, we develop a host of e-learning assets. This is virtual patients. We also develop tools like digital logbooks. So we're moving away from a paper-based way of supporting the educational training of medical licentiates. And this has been a very key partnership going forward. And we're also working with people in the more corporate space. As an example, Ambos is a company, and they're a medical education company, mainly based in Germany. I think 80% of German students are on the Ambos platform, and a good number of American students. And basically, it's quite a vast digital library of very well indexed medical education knowledge, and it's also self-learning. So they've been very generous, allowing the students in Zambia to have free access to their platform for their learning, which is a really key thing, because it's really hard sometimes for students to get access to good quality medical knowledge, especially when there's so few textbooks and there's so many students. Having a digital platform where they can get good knowledge has been really great. The Royal College of Surgeons in Ireland, of which you have Kuba Galewski on the line, who's going to talk to you shortly. We recently started talking, and we've recently partnered up with a colleague at the Surgical Society of Zambia on a new initiative, which is the Mel Tracker initiative. And what we want to do is, we recognize that there are many medical licentiates in Zambia now, and we're not appropriately doing research to see how they're doing. A lot of them face barriers in their practice. A lot of them face barriers in being able to practice to their full clinical competencies, to progress in their careers. And for us to be able to go to the Ministry of Health and decision makers to agitate for more support for MLs, we need good quality research. And in that respect, the three of us, that's Heidelberg, RCSI, the Surgical Society of Zambia, the four of us, and Salvador Med, have teamed up to start building and getting this really high quality knowledge set so that we can start advocating for more MLs. Our position is that the ML program should continue, even though there's a lot more, for example, physicians now being trained in Zambia, and there are questions that are arising from certain parts of the political space in the world of medicine, saying, well, are medical licentiates still relevant? And our position is they very much are. We still have a shortage of approximately 35 to 45,000 clinicians in Zambia to attain the WHO's minimum standard of clinician to population ratio. There's a huge number of clinicians that are needed in Zambia. The new government actually has proposed in its new budget to employ 11,200 new clinical staff. And we're really happy about that, because we do have a number of MLs who are waiting to be put in positions. But to agitate to get those positions, we need good quality research. And this is where the new partnership comes in. Okay, I hope that was informative. If you have any questions, I'd be very happy to answer.
Thanks, Petros. Thank you so much. That's fantastic. Very comprehensive. Can I just ask quickly, what led to Solid Ahmed getting involved in at the beginning? Why did they choose to get involved the way they have?
Solid Ahmed's focus, its raison d'etre, for want of a better word, is human resources for health in rural areas. And in many parts of Southern Africa, so we're based in a number of countries in South and East Africa, from Lesotho to Malawi, Uganda, Tanzania. And most of the country foci are on direct service intervention. So, providing cholera treatment, providing vaccinations, etc. I think there was a realization about 10, 11 years ago that actually we can do some systems changing. So it's not just focusing on putting a bandage in what a public health person would say. A public health person would call it a downstream intervention. We're saying, well, how can we manage the upstream intervention? How can we change the system? And I think that was Solid Ahmed's intention, was to say we'd like to see what we can do there. The focus, as an example, LED, so the Liechtenstein Development Service, they provide funds for us under the umbrella of vocational education. The fact that we're doing medical training is by the by. So Liechtenstein fund people to do engineering in certain parts of the world. They fund people to do agriculture in certain parts of the world. In Zimbabwe, they fund people to go learn how to be a hairdresser or a mechanic, because it's a vocational training. So we went to Liechtenstein and said, we want to support this medical cadre, which is vocational. It's not purely theoretical, as per our discussion about an hour ago. And I think that was the draw for Solid Med, is that we knew we could do something and we could pull the expertise together to focus on rural health and have this new clinical cohort be supported.
Yeah, they saw an opportunity to where they could make a difference. Yeah.
I mean, Liechtenstein have no financial interests in Zambia. This is pretty much a purely we realize we can help situation, and we like our model of education, and we're thinking maybe the rest of the world could use this vocational training model.
Yeah. Thank you, Petros. If anyone has a question they want to put to Petros, please, you could put it in the text box, chat box, or unmute yourself and pipe up.
Can I ask a question, John? Petros, has the Ministry of Health managed to sort of look at the staffing levels in the hospitals to take into account this? Because that was one of the problems we had when we were running or helping run St. Francis.
Yes, so as you might be aware, as everybody's aware, there's been quite a significant change in the executive and our new elections and peaceful elections. And we've been a model to the whole world, Zambia, actually, having come from South Africa. I know what that means to have peaceful elections. And the challenge with the previous administration was, and I've been involved in the talks with the various permanent secretaries and ministers to say, how do we get these? And there's always been this willingness not so much to talk about it, to talk about staffing. And the staffing with staffing doesn't just affect medical licentiates. There are quite a few thousand nurses who have not been absorbed into the system yet. So the challenge over the last few years seems to have been that the previous government were focusing on building assets and infrastructure projects. So if you drive to Chipata, for example, you'll pass a couple of very nice brand new hospitals, but they're not staffed yet. They're currently sitting empty. And a lot of investment has gone into infrastructure, but none of that investment seems to have gone into human capacity and human resources. And with the new government, we've seen, at least in the narrative, they'd like to change that. And it's only been recently that we've heard that narrative come through saying we'd like to hire the underutilized medical professionals. It was so my boss and I were chatting to the new Minister of Health quite recently, and she said, listen, I know that there's 500 nurses in this area who are not employed. That's my first job. I want to employ them. And we'd like the Ministry of Health to say the same thing with medical licentiates and doctors as well. So it's part of the narrative. Most of my work is, in economists speak, on the supply side. We're trying to supply more medical licentiates, but a lot of the advocacy that we need to do, the demand side, comes through the research that Jakub and I are going to be getting through with.
There's a question there, don't there?
Yes, I see.
Yeah.
Martin Ferns, once MLs have completed their training and are working in rural hospitals or health centers, do they have access to experienced support as they treat patients? Sometimes they do, sometimes they don't. Some medical licentiates are reabsorbed into their clinical officer posts that they recently left, in which case they would likely be supported by the physician on duty in terms of their carrying on their support. Some medical licentiates might be posted to a more rural facility where they are the head of that facility itself. And one of the things we're looking at with the Zambia Medical Licentiates Professionals Association, the kind of governing body for MLs, is what is the next step for MLs? What kind of support do they need, and what kind of education do they still need? I hope that answered your question, Martin.
Can I ask one?
Yes.
Could you advise if there is some sort of seamless progression for those who are so inclined to advance towards full medical doctor status?
Yeah.
Okay, so there is no seamless progression, and we've got a number of instances where we've got, for example, I was talking about a medical licentiate in St. Francis in Kantete. He'd been working there for many, many years, over 10 years as an ML, and he's now in year 3 of his MBCHB. So he didn't get very much. I think they took 2 years off his MBCHB, so he still has to do year 3, 4, and 5, and he still has to do 2 years of training. And he's a little bit irritated about that because he's got 10 years experience doing surgeries and working in a hospital. So they haven't yet found a pathway to MBCHB. But the thing is, this is where politics comes in. I don't think they want that pathway as such. What we're seeing is effectively MBCHBs interpreting MLs as a parallel medical program sometimes. So there's a lot of discussions to have about that, and that they haven't yet fully been addressed. Yeah.
Thank you.
Naomi has a question. I was wondering if students have to pay for their own education or if they're on scholarships to gain a license. If they have to pay the cost themselves, is the education affordable for students? They have to pay for their own education. The cost of training for a medical licentiate is approximately 21,000 kwacha per year. So you're looking at approximately £1,000 for the fees. And on top of that, they also, of course, have to support themselves. There's not much in the way of bursaries. Solidar Med actually built housing in many areas. We built housing along with the Clinton Health Access Initiative in Livingston, Solwezi, and Mansa, and Mongo. And the purpose of this was that so we could provide accommodation at a very good rate so that MLs could be trained. With the coming of LMMU, much of the facilities were co-opted into the LMMU architectures and infrastructure. And unfortunately, one of the first things they did, because they were struggling financially, was to really bump up the school fees and bump up the living costs. So students were paying approximately 3,000 kwacha per year to rent our facilities. And I think LMMU pushed that up to between 9,000 and 18,000. And that led to a lot of challenges for the students going forward because they don't get much in the way of financial support. A lot of them, to get through their exams, you have to have paid 25% of your tuition fees for the year to be allowed to sit your exams. And what tends to happen is the students accumulate debt and they have to find a way to pay off their debt at the end of their program or during their program before they can officially get their license and registered through the HPCZ, the Health Professionals Council of Zambia. Okay.
Okay, I think that's, thank you very much. Yeah, that's terrific, Petros. Thank you for the questions as well. We'll have another chance to think about these things when we hear from Jakub. Dr. Jakub Galewski is a health sociologist. He's director of the research program of the Royal College of Surgeons in Ireland, Institute of Global Surgery, and he has conducted research on lessons learned from the Medical Licentiate program. So he's kindly agreed to share his findings with us now. So, Kuba, welcome.
Yeah, thank you very much. Good afternoon. Thank you for having me. And it's been a pleasure to listen to Petros's presentation because that kind of sets the scene for the research findings that I would like to present. And Petros mentioned that our stance as a team working together is that medical licentiate should continue. And I would like to tell you a little bit more about the details. Why do we think so? Because there is a lot of lessons learned in the medical licentiates program. It's a very successful story so far in various areas. There are still some challenges that Petros mentioned, and I'll allude to them myself. But I think I would like to highlight the successes of within the medical licentiate program as the history of it goes by. We've been, as RCSI, we've been in Zambia. We've been working in Zambia for the past 11 years. We've had a number of different projects, and I would like to talk about one particular that we started that was focusing on the MLs and present lessons learned from that initiative. So the structure of what I would like to say of the talk today will have kind of four main elements. So I would like to highlight the problem with surgical care globally first, and then focus on the key issues that pertain to Zambia, the solution that is the ML program and the mechanics behind the ML training and practice. I would like to say also a couple of words about the contribution of the MLs to surgical care, the significant contribution that they make, and conclude with some suggestions for next steps. So, the issue of access to surgical care reached out to the news, and I guess you can see from the titles, here that I'll be showing, the 5 billion people have no access to safe surgery, and in 2018 there was a paper published in the Lancet that showed that twice as many die after surgery in Africa. So there's also an issue of quality of surgical care, or not maybe the quality, but outcomes of surgical care. And then at the policy level, there is also a push to include surgery as a core part of the healthcare system, even in the poorest countries, basically in all parts of the world. And just to give you a kind of a graphical representation of what is the problem with access to surgical care, you can see the red man on the graph, and these are people killed annually by not having access to safe surgery. And the blue man and the green man are the blue one is the combined deaths, annual deaths of HIV/AIDS related conditions, TB and malaria, and the green one is maternal health and under 5 children's deaths. So surgical conditions, outweigh are greater. The number of surgical deaths is significantly higher than all those different conditions combined. And if you look at specifically the sub-Saharan part of Africa, it is estimated that 95% of the population living there does not have access to surgical care. Moving on to Zambia, the table is that you see is from 2015, and the numbers are a little bit out of date. However, not much has changed since, because the only significant change on that in that table would be the number of people living in Zambia, which is currently around 18 million people. I think that in the area of surgical specialists available in the country, not much progress has been made. And if you look at surgeons, we are still talking about 100+ surgeons, around 20 anesthesiologists at the moment, similar number of around 60 obstetricians perhaps. So the ratio of surgical surgeon to 100,000, it remains still at around 1 per 100,000, while in Ireland, where I live at the moment, is the ratio is 27 surgeons per 100,000. So there is a huge disparity. There is a huge difference between those two settings, the developed and the developing world. So that results in a large proportion of Zambian not having access to safe surgical care, and the precise number is 74% of Zambians who live currently with no access to surgical care, nearly 100% of them in rural areas of the country. So in response to that challenge, we had a project that was called Coast Africa, Clinical Officer Surgical Training in Africa project, that was a European Union research initiative funded by European Union, a collaboration between us as RCSI, College of Medicine Malawi, because we had a similar, I won't talk about Malawi much, but there was the project was implemented in 2 countries, in Malawi and Zambia. So it was RCSI, College of Medicine, Surgical Society of Zambia, and Radboud University in the Netherlands, who helped us with costing of the initiative. So the aim of the Coast Africa project was very, very simple. We wanted to train medical licentiates and demonstrate effectiveness, safety, and feasibility of that training and its effectiveness in terms of enabling access to safe surgery for rural populations in Zambia and Malawi. In Zambia, there was, as Petros mentioned, the history of the medical licentiate program is will be turning into its 20th year next year. I think it started in 2001. So when we came in with the Coast African project, we want to align our surgical training with the existing program. So on top of the training that was offered to the candidates, we developed a 3-monthly advanced surgical skills that was delivered to them in Lusaka by surgical specialists. And then we deployed them for 24 months, for 2 years across 7 provinces in 8 district hospitals, when they were being supervised quarterly by a dedicated provincial surgeon visiting them, to supervise them. The central training that was delivered in Lusaka, the 12 weeks, 3 months central training that we delivered in Lusaka, had the following elements: essential surgical skills, trauma management, anesthesia, advanced life support, obstetrics, management, professionalism, and research. So that was the kind of essential package that was identified prior to the development of the curriculum through a situation analysis. and matched with the needs of a level 1 or district level hospital in Zambia. One of the questions that was asked whether medical licentiates have access to supervisors or surgical specialists once they are deployed to practice in rural areas. Yes, by law they should be supervised. This is a formal requirement for them to have to be attached to a surgical specialist, but that really happens very rarely, to be honest, rarely. So Costa Africa had that second element of mobilizing existing surgical specialists practicing in provincial hospitals to visit our trainees every 3 months to quality assure their practice, give them additional training on the job, but also meet with other practitioners in those facilities, other MLs, other medical officers, medical doctors, theater staff, and managers. The next aim was to review the practices, basically how to form the teams, what are the management practices when it comes to patients. And in between visits, we created a support system over the phone and WhatsApp and email, so medical licentiates could access in real time the knowledge and expertise of specialist surgeons in case they were stuck in theater. So the overall findings, just to kind of start with what we've learned in a summary, that MLs play a crucial role in delivering surgical services at district level. They provide the much needed essential and elective surgical care that would have not been available without them. They work very well hand in hand. In many occasions, they work very well hand in hand with medical officers, medical doctors. And what was interesting in our study that we found that they serve a kind of an informal training role for these medical doctors, because medical, as Petros mentioned, medical licentiate training is very hands-on, very kind of a practice focus, while the medical doctors training is not so much about hands-on training. And we've seen instances when there was a freshly graduate medical doctor with very limited or almost non-surgical skills. So the ML was the one who trained him on the job, and I'll be talking about that a little bit more depth in a minute. However, there were also challenges that we identified, so in certain places, there was a very good dynamics between doctors and medical licenses. In certain places, there was horror. There was no positive environment for the medical licentiate to practice because they faced professional recognition problems. And, because of that, there were tensions around the relationships with medical officers. And all of that resulted in medical licensees not being able to utilize the surgical skills to the maximum capacity, to the best. So some of detailed findings, we conducted interviews to find out how the MLs were received and perceived in facilities where they were deployed. And the overall perception was very good. So you can see the quotes on the screen. So one of the MLs said, look, there are no Zambian doctors here, so all surgery in the hospital is done by us MLs. So they fill the gap. There was nobody, there was an ML filling that gap, providing that surgical care. Second quote says, at district level, we have challenges that doctors are not able to fully participate in theater because they attend meetings, workshops, all of this different things. So the ML was the one who was always on duty providing surgical care for patients. In moving on to task shifting in places where other practitioners existed, where other practitioners were already there practicing, you can see there is a quote which starts with, I can tell that there was a huge difference. It was a really help and I had time to rest. So when the ML came, he was taking some work off the practice, the medical doctors, allowing him to basically take a rest, have a break, because in most instances there was only one doctor, and then when the medical licensing was deployed, there were only the two providers. The next thing that we observed is that there was a significant jump in the productivity of district level hospitals after MLs were deployed. The example here is the medical officer commented that in the year when they received the ML, they had 200 plus cases done in the hospital compared to 110 in the previous year. That was and the increase was attributed to the medical licentiate. The second thing was the scope of practice also expanded because they started doing laparotomies, intestinal obstructions, and all the different things that to do with abdomen and all the procedures, trauma as well. On the right-hand side, there is a quote about capacity building, and what I mentioned before, that medical licentiate played an informal role. When there was a positive environment to receive the medical licentiates, there was a lot of lessons that the medical benefits that the medical doctors got from having a surgically trained medical licentiate. And the doctor said in the interview, even when I came here, I wasn't so conversant with cesarean sections and all other small procedures, but I would always ask him, which is the medical licentiate, to show me how to carry out certain procedures. So there was a good environment, there was a good working relationship between the two. Moving on to productivity of medical licentiates, just to demonstrate a little bit about how they work in practice. This table looks a bit busy, but I'll highlight certain things for you just to draw your attention to what the key messages are. So we are in trauma now. This is the top row of the table. And then you can see that the trauma at the time of the study had 1 medical licentiate, and the third row, which is medical doctors, 12 medical doctors, right? So one licentiate, 12 doctors. Then moving on to another area, which is percentage of annual percentage of procedures done by those cadres. You can see that the 1 medical licentiate conducted 23.2 cesarean sections of the 100% done in that year by the hospital, while the 12 medical doctors did the remaining 75. So you can see that 1 ML absorbed 1/4 of the workload, and the other 75% was divided by the other 12, actually 15 if you include the other providers who are apart from medical licentiate. We also looked at the number of index procedures, general surgical cases, such as hysterectomy, salpingectomy, laparotomy, hernia, and hydrocele repairs. And then you can see that the single medical licentiate in trauma at the time of the study, again, absorbed 1/4 of the workload when it comes to general surgical cases versus the 70% done by 12 medical doctors. And if you look at, for instance, at Kalenia, which is the next row in the table, the situation is even more interesting, because the single ML versus the 5 medical doctors that they had conducted 60.8% of index procedures of the general surgical cases versus the 5 doctors who did nearly 40% of the general. So in conclusion, medical licenses were much more productive, and that is also reflected in that table, which shows that, on average, for instance, in Siavonga, the 1 ML would do 30 cesarean sections in a year, while medical doctors would 23, and medical licenses would do 16 index procedures, while an MD would do 3. So again, very highly productive and dedicated surgical providers. However, as in every story, there is also the downside or the darker side of it. As you see from this quote, the medical licentiate complained in one of the hospitals that at times my superior would question the kind of training I underwent and felt I needed to seek authority before carrying out some of the procedures. So that's where the MD ego, came in the way, disturbing the working relationship between a medical licentiate and a medical doctor. And in this example, you'll see even a greater negative impact, because the medical licentiate reported that I am having challenges because there are cases that I know I can do, but because there is someone who is senior to me, they have been referring those cases. So the doctor chose to refer those cases rather than to reach out to his ML colleague for advice how to operate those cases locally. Just to wrap up, conclusions. Deployment of surgically trained medical licentiate has been very effective in Zambia. It's a brilliant strategy, making safe surgery available and accessible in rural areas. And I forgot to mention that one of the studies that we conducted look at outcomes of surgical procedures compared between doctors and medical licentiates, and the outcomes were identical, indicating good quality of services, or comparable quality at least. Like I said, presence of MLs increases the volume and scope of surgery at district level. And Zambia is an example of a successful story where a mid-level country was introduced, which is something to be followed by other countries in the region, which is not easy because, for instance, in Tanzania, there was a program similar to the medical licensing program that was called Assistant Medical Officer Training. They had trained a lot of people in surgery. However, recently they were all banned from doing surgery because of the political situation that was more in favor of training medical doctors versus these middle-level cadres. So the last words would be really to say that medical licentiate and all kind of non-physician, clinician, non-doctor surgical providers deserve national, international recognition. And there's the whole question is how can we support that? How can we make that happen? And just to add a pinch of salt at the end of the presentation, the sustainability of this strategy in Zambia is uncertain because of what Petros alluded to, and I can confirm that there is a lack of professional recognition and lack of career paths. The bridging program does not exist for them to progress to medical doctor degrees, or even to progress within the medical assistant specialty to a master's degrees. That master's degrees in surgery does not exist currently in Zambia for medical assistants. Thank you very much. This is my last slide. Happy to take questions.
Yeah, I've got one. Hello.
Please go ahead.
What is the position in relation to anesthesia? Do the licentiates are they authorized to give local and full anesthetics?
They have received training in anesthesia, so there are instances. So I remember one of the hospitals when I went to do the interview, there were two medical licentiates, and they reported to me that in case they have a case in theater, one is the anesthetist, the other one is the licentiate. The other one holds the knife, and sometimes they swap. So they have a basic orientation in anesthesia, but this is not really what we would like to see in the long term. So there is the anesthesia is, when one looks at the kind of a whole spectrum of surgical care, there is quite a lot of initiatives to look at the ones to train the ones who hold the knife, the surgical, the ones who cut. However, there is the whole support system. The anesthesia is really the bottleneck. I was talking to a colleague of mine last week about the recent intake for into surgical, all sorts of surgical training. So they enrolled a good number of people into the surgical training, but no one really applied for anesthesia. Nobody wants to be the anesthetist because you're always the number two. Why would you train for so many years if you're never recognized for the work that you do? You make less money. Your name never appears as the one who successfully conducted the operation. Yet you are the one who keeps the patient alive, puts them to sleep, and wakes them up after the operation to make sure that that everything goes well. So this is anesthesia is really a fragile point in the whole surgical ecosystem. So thank you for that question.
Thank you. Just make an observation, if I may. Looking at the woeful state of the UK rural National Health Service for GPs, I must say there's a powerful case in principle for having something equivalent to licentiates in the UK.
Yeah, that's what we've been saying, that the problems that we see in Zambia or Malawi or anywhere in sub-Saharan Africa are not very unique to the region, because, for instance, RCSI, my own university, has already launched a program that is called PA, Physician Associate, which aims to do the same thing, obviously not to the degree of allowing people to operate, because there is a political climate that is specific to every country, but to fill that gap that exists within the healthcare service.
Thank you.
If I can add a point to that, I'm currently engaged with the group called the Wales Africa Health Links Network. So I studied in Wales and I have connections in Wales. And Swansea University has a physician associate program as well. And they're really interested to learn from the Zambian context, actually, about what physician associates do here. And actually, in terms of nomenclature, the International Association of Physician Associate Educators, they've been pushing for a long time to get physician assistant dropped as the nomenclature, and to push towards a professional naming of physician associate. And I believe they were successful in that earlier this year in shifting their group towards the physician associate status. But it's interesting, the UK seems to be wanting to create these cadres as well, as does Europe. They're based in France. There's some in Switzerland as well. So this may be where they're going. And I think the Global North has a huge amount to learn from the Global South in this space.
After training and posting, what is the retention rate of MLA?
There's a question in the text box there, either Jakub or...
what is the retention rate of MLs? This is exactly what we would like to find out in our recent research initiative, because we know that there is a lot of eagerness initially, among the trainees to serve those, the rural populations. But once they are faced with the reality of a district level hospital, that motivation drops. And I have conducted a study just to answer the same question in Malawi, and the retention rate is quite poor. And particularly what is damaging is the NGO sector, not to name names of certain NGOs, but they pay much better than the government, and they absorb these surgically trained people into circumcision campaigns or just managerial roles, taking them away from district hospitals, taking them away from operating theaters, damaging the healthcare system. So I think there is a lot of coordination that needs to be done between the NGO sector and the governments to prevent situations like that. So retention is another issue. There is people always talk about the brain drain problem that refers to, highly trained specialists being absorbed by high income countries. There is an internal in-country brain drain problem as well that happens in those low and middle income countries when richer organizations take away highly trained professionals from the poorer organizations supported by the government.
Yeah. Thank you. Thank you. I don't think any other points people want to raise, but I just wanted, it's so impressive to hear such a comprehensive evaluation of the program. With also such positive outcomes, positive results, and also highlighting perhaps one of the big issues for the future, the last point you made about the status recognition, the relationship with the other doctors and so on. I'm sure that's something that Petros is thinking about, and let's hope things can move forward. And it's impressive also to hear that Zambia might be leading the way in healthcare in rural areas and so on. I did want to ask quickly how does Zambia compare with other sub-Saharan countries in this whole area?
I can speak about the surgical side of things. I think Zambia is really doing very well, because Zambia was, I'm not sure if you've probably, you haven't heard that there was an initiative by the WHO, supported by the WHO organization, that to create surgical planning, as part of the, to come up with surgical plans. And so Zambia was the first country on earth to come up with a national surgical anesthesia and obstetric plan, providing a blueprint for the government how to get to a point where the system is stable and responsive enough to the needs of the patient. So Zambia has been really at the forefront of the whole initiative. And the success of the Medial Licentiate program, they have opened Levi Mwanamwasa recently, Zakomzi, which is another college that they opened just purely for surgical training. There is a lot of good stuff that is happening in Zambia, and I think it's worth talking about it on and on, because when people talk and think about Africa, there's always the kind of a darker cloud among the continent, but there's a lot of good stuff that is happening, and I think Zambia has a lot of positive things to tell to the entire world, and make people learn from them.
Well, thank you very much indeed for your talk.